The department is yet to submit its official position paper to the committee. However, we would like to convey our initial position, observations, comments, and recommendations. At the outset, the department expresses its support to House bills seeking the improvement of delivery of health services. Health services is a devolved function of local government units under Section 17 of the Local Government Code of 1991, and LGUs are in the forefront of the delivery of health services in the local level. Section 7 of House Bill 6456 identified local government units to be responsible in the establishment and operation of physical and rehabilitation medicine centers in local level. The department acknowledges that LGUs have different financial cap- capability. Concerns arise on the ability of LGUs to establish these centers due to challenges on funding, such as office space, personnel, and other related administrative expenses. Also, this is to inform the committee that the Office of PIDAW, or the Persons with Disabilities Office, in LGUs are also a challenge. Not all LGUs have a PIDAW office, and some LGUs only have designated persons with disabilities officers. These might be a challenge both for personal and administrative challenges in the implementation of the bill when it's enacted into law. Thank you po, Mr. Chair.
Thank you, Attorney Sala.
Thank you.
Uh,
Nalit.
the last, but very important from the Department of Budget and Management, Mr. Reynaldo Moreno.
Magandang umaga po, Mr. Chair, and to the honorable members of this committee at sa mga kapwa po kawani pamahalaan at pamauhin. Ang DBM po ay nare-recognize yung noble intent ng bill. While we recognize it, our concern is if the proposed centers po that will be established will be owned and operated by the LGUs concerned. We respectfully recommend that the funding requirements in its implementation or the implementation of the bill will be to the local funds of the LGUs. If in their program or budget proposals, the needed support assistance to the LGUs concerned, specifically on the low income LGUs, sir. Thank you, sir.
Thank you. Before we proceed, we'd like to acknowledge the presence of our committee member, Honorable Salvador Prieto of the 6th District of Bulacan, Honorable Agustina Dominique Dichetina of Pancho of the 2nd District of Bulacan, and our Vice Chair, Honorable Larney Lavin Roque of the 4th District of Bukidnon. We now, at this point, we now recognize our members who would like to interpellate our resource persons. Honorable Macapagal Arroyo.
Mr. Chair, the most important element of this bill is the funding. And the bill, as authored, says that it's going to be charged to the department. Now we have a resource person here saying that it should be charged to the local government, except for the poorest municipalities who will be given support, but not entire, not the 100% subsidy. So this is the important question: where does the committee stand on this issue of the funding? If the DBM says that if the DBM is uncomfortable, how are we going to get this? Even if it's passed, how are we going to get it implemented? In fact, as I was telling you earlier, Mr. Chair, Congressman Vergara and I have filed a resolution some time ago to inquire into all those unfunded additional hospital beds bills. So here now we are going to are we going to pass a bill where again it will be unfunded, even if we even if we throw it shove it down the throat of whoever has to pass it? So, that's my question. How are we going to solve the issue of the funding?
And unfortunately, we don't have the authors here. But I agree with the Honorable Macapagal Arroyo. I think very important is how do we, where will be funding be coming from? Will it be from the Department of Health or from the local government unit?
As
Yeah.
Department of Health.
Uh,
So,
uh, uh, may I ask DOH if for your comment if this will be under the Department of Health and how much would it require
Okay.
to fund establishment of rehab centers? By the way, will it this will be initially one in every province? Is it it's province wide, no? It's province wide initially. Yes, Dr. Dina.
Hi. Good morning, Mr. Chair. It is the department would recommend that the establishment of these centers be lodged under the local government units, since the physical and rehabilitation medicine centers, based on our research stratified framework for physical and rehabilitation medicine care, at the primary level should be devolved to the local government units and is not within the purview of our specialty centers for physical and rehabilitation medicine care po. Thank you, Mr. Chair.
Arroyo.
in my many decades as legislator, including in the Senate, every time we passed a bill and then charging it to the local governments, the Union of Local Government Authorities would always say, why are you dictating on us where we will put our money? We are under the local government code, it's supposed to be devolved and we're supposed to make our own decisions. So are we going to again shove this down the throat of the local governments and then for them to just say that they don't have the money and why are you imposing it on them?
Honorable Pancho, and then
Mr. Chair, we have to consider the priorities of the LGUs because if the priority is agriculture, hindi sila mag-i-invest sa health. But if their priority is education or health, top priority na yung health. So it depends on the priorities of the LGUs. Kasi yung existing RH natin, nakikita natin hindi pa rin complete ang facilities and even the staff. So if this will need another pondo, then it will be very hard on the part of the LGUs. Thank you po, Mr. Chair.
Good morning, Mr. Chair, fellow representatives, and of course our resource persons. I just would like to, in addition to all the comments, well, I'm a doctor and I fully support the need of the rehabilitation centers in um in our country. However, I have some issues. Number one, I think it's not really practical to have a rehabilitation center in every LGU because like just like what Representative Arroyo and Representative Pancho said, yung RHU nga hindi pa hindi pa nila ma-complete at ma-develop how much more a rehabilitation center. And then number two, I think we also have issues about manpower. Not all LGUs have physical therapists. Not all LGUs have orthopedic doctors. And of course, yung mga staff pa sa rehabilitation center. And of course, saan kukunin ng LGU yung budget for the machines, for the devices to be used for the patients. And then number three, issues sa PhilHealth. Will they cover everything? The rehabilitation? Halos every day, halos every week, will they cover it? I think in reality, hindi talaga kaya. But I suggest, if ever, um, we could have like the Philippine orthopedic centers, center here in Manila. We could probably have like one per region, if ever kakayanin, but it would be hindi na siguro LGU yung magfa-fund. It's more of the DOH, which I'm sure medyo ano rin, medyo ano rin sa budget, but if ever lang. But I think parang hindi siya doable and hindi siya practical that we should have a rehabilitation center in every LGU. Thank you. Per
May
parang
I ask?
per province or per region or yung sa
Uh,
hospital na lang siguro. For example, DOH retained hospital, tertiary hospital. I think they should be obliged or that you should have a budget for that na parang every tertiary hospital per region or per province should have a rehabilitation center. Thank you.
yes,
Yes, thank you very much, Mr. Chair. The Department of Health acknowledges the inputs raised so far. We also want to provide the information that yes, we agree that the tertiary hospitals should have the capacity for primary rehabilitation medicine care. As a matter of fact, the establishment of PRM, that's physical rehabilitation medicine units, is a licensing requirement for level 3 hospitals. So this is included in our policies and in our requirements for tertiary hospitals. And furthermore, in pursuant to Republic Act number 11959, the Regional Specialty Centers Act, the DOH has designated DOH hospitals to establish their physical rehabilitation medicine specialty centers. So these are distributed across the region, strategically distributed to ensure that each subnational group in Luzon, Visayas, and Mindanao will have access to specialized physical and rehabilitation medicine care. So we acknowledge that the intent of that when we reviewed the bill, the intent seems to be um, expanding the access of primary level rehabilitation medicine care, which is different from what is expected to be offered by the tertiary hospitals. But yes, we do acknowledge that there are limitations within the due to funding, to human resources, and that is those are the hindrances that we see in the implementation also of this the possible implementation of this bill. Thank you, Mr. Chair.
yes, may I ask, are all regions, I mean, do all regions have rehab centers? We have 18 regions. Lahat ba may rehab centers na? May I ask DOH or from farm? Dr. Goko?
From the Philippine Academy of Rehabilitation Center. At the moment, all physiatrists are seated from Luzon, Visayas, and Mindanao. Um, as for the rehabilitation centers nationwide, only 28% are owned by the government and 72% are privately owned. So this gives us a major concern on how we are seated nationwide. The bill allows flexibility through province-wide rehabilitation networks, shared services, and telerehabilitation models that we are now instituting nationwide so that even resource-limited municipalities can access specialist-guided rehabilitation services without immediately establishing fully independent centers. We fully understand that resource is a problem. However, the role of LGUs is very important, already playing a primary role in delivering devolved health services. House Bill 06456 strengthens the mandate and integrating rehabilitation into local health systems. It does not impose an entirely new obligation upon LGUs. Rather, it operationalizes rehabilitation as part of the integrated healthcare system. Now, as for funding and staffing, we are all challenged with this. With only 595 physiatrists nationwide. However, I assure you, even with this geographically isolated areas, we have reached our countrymen because we want We want our Filipinos to be integrated into the health system, including the disabled. Um, exact funding source, how do we do it? It's really a main challenge. We have special health programs from the Universal Healthcare. We have DOH Health Facility Enhancement Program. I agree with DOH with House Bill 1680. Uh, um, the Republic Act already for the apex hospitals, which is only situated in tertiary level hospitals, not the primary levels, which we are taking care of. And we also have PhilHealth reimbursements. As of the moment, we only have 36 currently accredited PhilHealth rehabilitation medicine centers nationwide. And we want to improve on this because PhilHealth covers rehabilitation and assistive devices that are very important for our patients. We are offering or suggesting phased local government counterpart funding and, of course, public private partnership. If you will all be one with us in the Philippine Academy of Rehabilitation Medicine. As of now, our data shows that we have 5,600 physical therapists. Not all of them have jobs. And we want to open these jobs for the rehabilitation centers that we are trying to open in the local government units. But as for our part in the Philippine Academy of Rehabilitation Medicine, we have also reached our local levels through um, assistance and trying to go with the meetings of our local governments to pursue this noble program within the local government units also. Thank you.
Thank you. I was asking, lahat ba ng region ay mayroon ng rehab centers?
Yes.
Kasi, yes.
Yes.
Okay, so
Yes, for the
from the
regions.
region, if all regions have rehab centers, our next target should be by provinces. So,
Yes.
81 provinces. We can target siguro mga uh, GIDA, GIDA
Yes.
areas as priority provinces where to establish the rehab centers. Now, my next question is, there are two factors na challenge, very challenging factors: the funding and, of course, the human resource, the rehab doctors. We only have, as you said, about 500 rehab doctors. So my question now is, how much does it cost to establish a rehab center?
For the infrastructure, we are prepared and we have researched that as of the current moment that um, the standards of our infrastructure programs, we calculate about a 5 million
And,
budget for the primary rehab
and the
center.
human resource, how much, more or less, estimate, how much does it cost? DOH, do you have any idea?
Wages, basis, a monthly basis, we are spending 100,000 as a budget. Uh, Physiatrist, the physical therapist, and primarily, if given given the chance to have an occupational therapist or a speech and language pathologist in the area, but we will be fine with one physical therapist and one physiatrist as a team in its initial phase.
Regarding po the official figures, these are not yet available since we would need to estimate the based on identified infrastructure, equipment, and human resource requirements for these centers, which are not yet determined po at this time. But thank you, Mr. Chair.
Well, time exact estimate how much does it cost? So, okay. Um, yes, the Honorable Gorriceta.
Mr. Chair, in addition, maybe what we can do, of course, no, we can not really like act it ASAP because of the issues, no. But I think what we can do now is for the DOH and the DBM, maybe we can add more plantillas for the PTs and the OTs because, like for example, in our region in Western Visayas, in Iloilo, we have a tertiary hospital, but our rehab center is too small and they could just accommodate a few patients. Number one, the issue was because of the plantilla that they only have two or three plantillas for the physical therapies, the occupational therapies, and plus the limitation of the speech therapies, though, because actually we have only a few speech therapists around the country, right? And then for the devices and the machines, I think that was also an issue because of the budget. So I think what we can do is for the DBM and the DOH, if we could like add more plantillas and budget for these facilities in the tertiary hospitals. Thank you.
Thank you. Before we proceed, we'd like to acknowledge the presence of our Vice Chairperson, Honorable Julius Cesar J. Vergara of the 3rd District of Nueva Ecija, Honorable Ching Bernos of Party List Sulid North Party, and our Vice Chair, Honorable Milagros Aquino Magsaysay of United Senior Citizens. Thank you. Yes, Honorable
Office po.
Hoves.
Si Medicine po, no? In the Universal Healthcare Law, it says there that the primary care provider must be able to provide comprehensive care to include rehabilitation medicine. And the specialists are actually now submitting in PRC the level alignment matrix in terms of competencies for specialists and diplomates and fellows. Uh, but the competency for primary, there are limited number of physiatrists in the Philippines, but we have more primary care physicians which should be capacitated now to provide the primary care rehabilitation medicine. What is happening now is that there is limited capacity, limited competency of these primary care physicians to do rehabilitation medicine. So it's nice to have the rehabilitation centers in regional, which the regional hospitals already have, no? Unfortunately, the community-based rehabilitation services, yun po yung nagkukulang, no? And this can be done by the primary care providers. So the PRC would like also to uh, l- uh, to no, regulate the practice of rehabilitation medicine at various settings. It's not only in hospital setting, those who are going home-based rehabilitation. From observation, there are difficulty of patients now who are uh, coming to rehabilitation facilities to avail of these services. Thank you.
Thank you. Yes, Honorable Arroyo.
Mr. Chair, among all of among all of the comments made earlier, really is the issue of the funding. But I like the recommendation regarding exploring public-private partnerships. And I think that that's important enough and is empowering enough to be included in the bill. In other words, when you say look for funding, include that as an option. Thank you, Chair.
Thank you, Honorable Arroyo. Any other comment before we act on the bill?
Mr. Chair, I'd like to move to the passage of this bill subject to technical consultation. So move, Mr. Chair.
So there's a motion to approve the bill subject to technical consultation. Duly seconded. Hearing no objection. House Bill number 6456 is now approved. A reminder to our resource persons, please submit your comprehensive or complete position paper to this committee. maybe in a week's time. Thank you.
Mr. Chair.
Yeah.
Vergara, gusto ko lang hong mag-add ng konti. I'm sorry, but I was quite late. Uh, ang importante po kasi, narito rin yung Department of Development and Planning, DepDev. Kasi ho, yung DepDev, 1 taon pa lamang po ang tanda niya. So, pero the very word, Department of Development and Planning, dapat po ay dibdibin nila yung salitang yun. So, lahat po kami na palagay ko po, lahat po kami ng mga kongresista, meron pong kanya-kanyang pet bill. Tulad po ni kagalang-galang Rufus Rodriguez and Maximo Rodriguez. Lahat po kami, meron po kaming pet bill. Ngunit, parating ang salita, walang pondo. So, dapat talaga na bukod doon sa sinabi po ng ating former President Arroyo na include private, public-private partnership, eh, dapat talaga yung DepDev, magkaroon po ng insight sa lahat ng bagay na nangyayari sa Kongreso at Senado. At nang maiplano nila bawat rehiyon kung yung mga pinagbigyan po na batas ay magkaroon na ng katuparan. Whether it be in health or in public works or in any other committee. Kailangan po talaga na I highly suggest that DepDev should always be present because of they should coordinate with the proper agency and plan ahead. Kung nangyari po, ang gagawin nila is 6-year plan for a president. Hindi naman po pwede na 6-year plan lang. Kailangan ho, malayo yung paningin. Malayo ng konti yung pananaw. Dahil yung lumaki po ako na sa isang salita na ang malayo ngayon, malapit bukas. Malayo ngayon, pero ngayon, bukas malapit na. Ang hirap po, yung planning natin ay if 6 years lang, kulang. Kailangan ho long term ng konti. So, yun lamang po ang gusto kong i-add dahil kailangan po natin na ma-realize na maraming magagandang bill ang bawat kongresista, ngunit hindi nagkakaroon ng pagkakataon dahil sa much needed funds. Yun lamang po.
Thank you very much, Honorable Vergara, for your input. We'll take that into consideration in the preparation of the final substitute bill. For the resource person on rehabilitation medicine, you are now excused. We now move to the second agenda, the House Bill number 2943, ANAP, integrating preventive and lifestyle medicine into the Philippine healthcare system, appropriating funds therefore and for other purposes, authored by Honorable Kathryn Joyce Gorriceta. Dr. Gorriceta is now recognized.
Thank you, Mr. Chair. Good morning once again. I stand before you today not just as a representative, but as a doctor. Every day in my practice, I have seen the same heartbreaking story. a breadwinner in his 40s suffering a stroke, a mother losing her sight to diabetes, or a family sinking into debt because of chronic illness. This is the reality of non communicable diseases, or NCDs, in the Philippines. Today, I advocate for House Bill 2943, or the Preventive and Lifestyle Medicine Act, through three simple lenses: the necessity, the practicability, and the beneficiality. To the members of the committee, NCDs like heart disease, cancer, and diabetes are the leading causes of death in our country. They account for 68% of all deaths in the Philippines. We are losing Filipinos in their prime between the ages of 30 and 70. These are the years when they should be working for their families and building our nation. Right now, our healthcare system is a sick care system. We wait for people to get sick before we treat them. We must pivot. We need this law because we cannot continue to watch our people die from diseases that are, in many cases, entirely preventable. Some might ask, is this too expensive to implement? My answer is no. In fact, lifestyle medicine is the most practical tool we have. Lifestyle medicine isn't about expensive machines or imported drugs. It is about the six pillars, which are healthy eating, physical activity, restorative sleep, stress management, avoiding risky substances, and social connection. This bill is practical because it doesn't reinvent the wheel. It integrates these interventions into our existing hospitals, rural health units, and field health packages. It trains our current health workers to be lifestyle medicine coaches. We are simply giving our doctors and nurses a better, more natural prescription to give to their patients. The benefits of this bill are felt in the heart and in the pocket. For the Filipino family, it means remission and reversal. Instead of taking maintenance medicine for 30 years, a patient can actually get better and live a drug free life. For the government, research shows that investing in NCD prevention can save the Philippines up to 4.8% of our annual GDP. Every peso we spend on lifestyle medicine today saves us thousands of pesos in intensive care and dialysis costs for tomorrow. For the poor, this bill ensures that the underprivileged have access to the same lifestyle interventions that were once only available to those who could afford expensive wellness centers. My dear committee members, they say health is wealth. But for many Filipinos, sickness is poverty. House Bill 2943 is our chance to change that. Let us move from just treating the disease to actually creating health. Let us give our people not just a longer life, but a better quality of life. So I respectfully seek the immediate passage of this measure. Thank you.
Thank you, Honorable Gorriceta. From the Department of Health, we now recognize Dr. Dominic Madumba.
Magandang umaga po sa ating lahat, sa members po ng Committee on Health and Care. The Department of Health recognizes the noble objectives of House Bill number 2943 as a measure that seeks to promote preventive health care, reduce the national burden of non-communicable diseases, of course, lower the long-term health expenditures, and strengthen the implementation po of our universal health care and improve the overall quality of Filipinos. Sa pamamagitan po ng pagsama ng preventive and lifestyle medicine sa ating sistemang pangkalusugan, ito ay isang cost-effective na hakbang na hindi lamang makapagligtas ng buhay kundi makakabawas din po sa pangmatagalang gastusin sa kalusugan at pagkawala ng produktibidad na dulot ng mga chronic conditions. Ang inisyatibong ito ay naayon din po sa universal healthcare dahil itinataguyod nito ang integrasyon ng preventive interventions sa parehong pampubliko at pribadong healthcare delivery systems. Kinikilala rin po ng Kagawaran ng Kalusugan ang kahalagahan ng pagsama ng lifestyle medicine sa edukasyon ng mga health professionals at sa pagsasanay sa ating mga community health workers upang higit pang mapalakas ang kakayahan ng ating healthcare system sa larangan ng preventive care. The Department of Health respectfully commits po to submit a more comprehensive position paper containing details, comments, and inputs and recommendations for the consideration of our legislators. Maraming salamat.
Thank you, Dr. Madumba. Next is from the Department of Education, uh, Assistant Secretary Janir Datukan.
Good morning, Mr. Chair. Good morning, honorable members of this committee. Sisigaw na lang po ba? Ayaw talaga. Napunta itong mic. Hello. Mr. Yay, clap, clap. Sorry po. Pasensya na po, Mr. Chair. On the part of the Department of Education, we recognize the importance of House Bill number 2943 in strengthening preventive and lifestyle medicine approaches within the Philippine healthcare system. The proposed measure aligns with national commitment to promote health consciousness, prevent non-communicable disease, and empower Filipino citizens to adopt healthy and sustainable lifestyles. DepEd supports the intent of the proposed legislative law. Clearly, it's promotes okay naman po, no? Promotion, disease prevention, physical activity, food literacy, stress management, behavioral change interventions. These principles are actually consistent with the goals of the revised K to 10 curriculum, specifically within the physical education and health learning area. However, we note that several provisions provided under Section 9B of the bill, particularly the integration of age appropriate. Okay, sorry. Particularly the integration of age-appropriate lifestyle medicine subjects into the grade school to senior high school curriculum are already substantially embedded po in the existing and revised K to 10 physical education and health curriculum. The current curriculum already incorporates competencies related to preventive healthcare, e-health literacy, healthy lifestyle behaviors, physical fitness, food literacy, stress management, and prevention of non-communicable diseases. In view of the foregoing, the Department of Education reiterates its support for the proposed legislation and recommends policy harmonization and strengthened implementation to avoid duplication of implemented learning competencies, strengthening existing education programs, teacher training, and interagency collaboration will further advance the shared national goal of developing literate, physically active, and wellness-oriented Filipino learners. Mr. Chair, all of these are incorporated in a very comprehensive position paper that we are just seeking clearance from our principals and then we'll submit po to the committee. Thank you, Mr. Chair.
Thank you, Sir Datukan. From the Philippine College of Lifestyle Medicine, Dr. Michelle Palma.
Good morning, everyone. For decades, the Philippine healthcare system has been largely designed to treat disease only after it has already taken hold. Yet today, we're confronted with a very different reality. One, that non communicable diseases such as heart disease, diabetes, cancer, and chronic disease have become the leading causes of death, disability, and financial hardship among Filipinos. and these conditions are no longer isolated medical concerns. House Bill 2943 responds to this urgent challenge with a bold and transformative vision to integrate preventive and lifestyle medicine into the Philippine healthcare system. At its core, the bill recognizes a fundamental truth that many of these disease burden of our nation are largely preventable, manageable, and even reversible at some point through evidence based lifestyle interventions. This is not alternative medicine, this is not complementary medicine, but this is the initial input, the initial management unanimously recommended in all clinical practice guidelines for non communicable diseases. So, our goal here is instead of waiting for illness to progress, this measure seeks to reposition healthcare toward early risk detection, behavior change, and long term disease remission. The proposed law envisions a healthcare system where lifestyle medicine becomes the first line of care and not the last resort as unanimously recommended in CPGs. From primary care centers to tertiary hospitals, patients are envisioned to receive not only medications, but also structured programs to achieve sustainable lifestyle modification. Care will become more patient centered, coordinated, and holistic, addressing not just the symptoms, but the root causes of the disease. Also central to this transformation is the establishment of lifestyle medicine services framework, which will guide the implementation of programs in both hospital and community settings. These programs aim to improve quality of life, reduce complications, and empower patients to finally take an active role in their own healing journey. Recognizing that such a shift requires a strong workforce, the bill emphasizes the development of a new generation healthcare professionals, lifestyle medicine specialists, allied health providers, and health coaches who are trained to deliver evidence based, behavior focused care. It also calls for integration of lifestyle medicine into medical education, ensuring that future health professionals are equipped not only to treat disease, but have the lens to somehow catch it early, prevent, and reverse it. We have current collaborations with several DOH CHDs and hospitals in training primary care physicians and allied health professionals to provide lifestyle medicine programs. Unfortunately, once once the directorship has changed, then the direction also will change. Importantly, the bill aligns with the vision of universal healthcare, reinforcing the shift from reactive system to one that prioritizes health promotion and disease prevention. It also fosters collaboration across sectors, health, education, labor, and most importantly, agriculture. Recognizing that health is shaped not only in our clinics and hospitals, but in the environments where people actually live, work, and learn. So finally, House Bill 2943 is more than a policy. It is a paradigm shift. It calls for reorientation of our healthcare system towards prevention, empowerment, and sustainability, utilizing presently existing programs and resources allocated for lifestyle related disease within rural health units, hospitals, and full health packages. We will just integrate this intervention into the existing programs, thereby not requiring too much budget or more money to operate this.
Thank you, Dr. Palma. Before we proceed, we'd like to acknowledge the presence of our committee member, Honorable Johan Monique Bautista of Party List Trabajo. Thank you. From PhilHealth, Mr. J. Bernolia.
Magandang po mula po sa PhilHealth. Amin pong kinikilala ang pagkakaroon ng House Bill number 2943 at ito po ay aming susuportahan. Kung kinakailangan magkaroon ng isang interagency committee, kami po ay nagbobolontaryo para kung kinakailangan pagandahin ang kasalukuyang benefit po na binibigay namin sa rehabilitation ay mas magpaganda at, at maging beneficial po sa ating kapwa Pilipino. So yun lang po, magandang umaga.
Thank you very much. From the Professional Regulations Commission, Honorable Policarpio Joves Jr.
Mr. Chair, the Professional Regulation Commission supports House Bill number 2943 and recognizes preventive and lifestyle medicine as a career progression pathway for healthcare professionals. We are likewise revising the table of specifications so that preventive and lifestyle medicine shall be included in the physician licensure examination, aligned with primary healthcare. Thank you very much.
Thank you, Honorable Joves. From TESDA, Sir Carlo Ray Paliado. TESDA? Anyone from TESDA? Uh,
Hey, good morning, Mr. Chair. I'm calling Eduardo, the supervising TSD specialist in technical education and skills development authority. So with respect to House Bill number 2943, it supports the integration of lifestyle medicine into the Philippine healthcare system. Particularly, its focus on preventive and promotive healthcare. So TESDA recognizes the community level health workers play a vital role in advancing the objectives of the bill, especially in promoting healthy lifestyle, disease prevention, and health education at the grassroots level. So TESDA believes that incorporating lifestyle medicine-related competencies into technical, vocational, and community-based health training programs would strengthen the country's primary healthcare framework. So this is particularly relevant for barangay health workers or BHWs, barangay nutrition scholars or BNS, and other community-based workers who are often within TESDA's training reach. So TESDA likewise notes that on the section 9 of the bill mainly pertains to undergraduate and postgraduate medical education, residency and fellowship programs, and licensure related matters, which properly fall under the jurisdiction of the Commission on Higher Education, the Professional Regulation Commission, and the relevant professional bodies. So in this regard, TESA's role is supportive and complementary. Nevertheless, TESDA respectfully recommends that the bill expressly recognize the TVET two-degree matriculation pathway under RA 10647 or the Ladderized Education Act to ensure that competencies acquired through TESDA programs may be properly credited should TVET graduates later pursue allied health degree programs, which there is already a what we call or PCTS or under the Philippine Credit Transfer System. Thank you.
Thank you, Mr. Paliado. From the Department of Interior and Local Government, Attorney Noel Sala.
Good morning again, Mr. Chair. The department is set to submit its position paper on House Bill 2943 or the Preventive and Lifestyle Medicine Act. However, we would like to convey our support on the proposed preventive and lifestyle medicine health development of local government units pursuant to Section 17 of the Local Government Code of 1991. The department also supports the provision that identify the Department of Health as the primary implementing agency in implementing this proposed act when it acted into law. It was also observed that the LGUs will serve as indispensable partners in the implementation of this measure once enacted into law. The department stands ready to collaborate, cooperate, and coordinate with the Department of Health and is ready to closely monitor local government units' compliance with existing laws, especially on health-related laws in the promotion of health services. The department will submit a comprehensive position paper once it receives clearance from the appropriate uh, office. That's all po, Mr. Chair. Thank you po.
Thank you, Attorney Sala. And last, from the Department of Budget and Management, Mr. Rinaldo Moreno.
Good morning po, Mr. Chair. The DBM po support the bill and we differ po sa DOH on the other provisions of the bill. However, in the funding support po, we suggest to section 14 po, we suggest to
Mr. Chair, puwede po bang pakiulit ni pakiulit po at
Pakiulit daw, Mr. Moreno.
the DBM po supports the intention of the bill and we defer to the DOH on the specific provisions of the DBM. However, in section kung para saan po yung health trust funds, yun po yung gusto namin maklarify, Mr. Chair.
Can we have a 2-minute suspension so we can fix the sound system? But before we proceed, we'd like to acknowledge the presence of our committee member, Honorable Florabel Yatco of Party List Nanay. Thank you. Meeting is resumed. Honorable Gorriceta.
Hello.
Regarding the question from DBM, the trust funds. Actually, sir, this trust funds will come from our private funders. Just like, for example, presently we have Rockefeller Foundation from the U.S. They already promised to help the Lifestyle Medicine Society in our advocacies and programs, and we also have partners from Europe and other countries. So, yeah. Thank you.
Yes.
Question, Mr. Chair,
No, no. It's
yeah, the answer to the question of DBM, the funding, the
DBM?
trust fund, health
Okay.
trust fund.
DBM?
Yes, Mr. Chair. Uh, Thank you, ma'am. Ang susunod po na katanungan po ay sino po ang manage ng nasabing trust fund? Nabanggit po ninyo na identify po yung mga sources of said trust fund. So yun po yung next po na gusto po namin ng clarification, Mr. Chair. Thank you.
It would be the Lifestyle Medicine Society po of the Philippines. It would be a private, it's just like a private partnership po.
Mr. Chair,
Yes.
siguro po ang mungkahi lang po namin para po maiwasan din po yung kalituhan, baka po mas mainam po na merong separate na provision tungkol dito.
Yes.
Kasi pagka po nasama po dun sa provision na ito, it seems na parang it's government.
Yeah.
So yun lamang po yung aming
Ikat
mungkahi.
lang.
Thank you.
Note po.
Thank you,
sir.
ma'am.
Thank you. Thank you for the suggestion.
Can you I mean from the DBM?
DBM. Yung gumulo na.
No, no, no. Can we have the DBM again on the your last position paper, position? Because Honorable Vergara wasn't able to appreciate your statement.
Yes, Mr. Chair. The DBM po support the intent of the bill, and we differ po sa DOH on their coverage provided in the provisions of the bill. And we suggest po to solicit the comments of the PAGCOR and the PCSO as mentioned in Section 14 of the bill, and request for the clarification on the proposed health plans as mentioned in the said provision, Mr. Chair. Thank you.
Please submit your complete position paper to this committee, and that includes also the all other resource person to please submit your position paper to this committee. Just a clarification, medyo bago lang sa akin yung lifestyle medicine, ano? May I know how many years ang residency program ng lifestyle medicine, and what are the institutions that are accredited training centers for lifestyle medicine?
Thank you for the question, Mr. Chair. The preventive and lifestyle medicine training program is currently in place in different interprofessional education. We currently have a master's degree in public health, majoring in lifestyle medicine, and that's already in place within the Adventist University of the Philippines College of Health. And we have also integrated lifestyle medicine competencies within medical undergraduate medical educations in several colleges and universities. With regards to residency program, it's a 3-year residency program, and it's an affiliate specialty society under the Philippine Academy of Family Physicians. And currently, because this is a new medical specialty in the Philippines, officially introduced in the country in 2015, we started with CME track training program, which is open to any medical specialty. The basic entry level here is a general practitioner, and that's the current CME track. And then we already have the residency program, which is also implemented either as dual track in some residency programs with family medicine, family and community medicine residency program. Apart from that, Mr. Chair, we already have the sub-specialty training in lifestyle medicine. So this is a 2-year fellowship training within three consortium training institutions existing in the country, primarily the University of the Philippines, Philippine General Hospital, the Southern Philippine Medical Center for Mindanao, and then we have St. Paul's Hospital Iloilo for the Visayas.
You have two programs. Yung isa parang subspecialty program,
Yes,
the family
yes.
medicine, and
Yes, Mr.
there's a
Chair.
separate
For the
residency program
specialization.
for
Yes.
lifestyle medicine and preventive medicine.
Yes. Preventive and lifestyle medicine.
Preventive and lifestyle medicine. May I know how many, and then you take your specialty board examination.
Yes, we have a
May I know how
specialty
many
board
members
examination.
are presently
Currently, there are over thousands of us already all over the country. So this is one track that we're looking forward.
1,000,
Over
more than
1,000,
1,000
all over the
board
Philippines,
board
boarded.
diplomates in
Yes,
lifestyle?
yes, boarded in
Okay.
lifestyle medicine. Mr. Chair, this is where we're looking forward to having our DOH physicians actually get a specialization track. You know, we know that most of them are general practitioners, and this is a good track for them to go through specialization in so that they would have that competency in implementing preventive and lifestyle medicine.
So you have training centers in Luzon, Visayas, and Mindanao.
Yes, Mr.
Okay.
Chair.
Thank you, Dr. Palma, for educating me.
Chair,
Yes, Honorable Cruzado.
just like to ask DOH kung ano na yung mga ginagawa natin with regards to lifestyle medicine. Kasi as I know, we have also some trainings on that. We have some exposures on that. Do you really have uh, a program na program coordinators for every regions, for every province that handles lifestyle medicine? Thank you.
Thank you, Mr. Chair. So for these ones, actually, when we look at into the different pillars of the proposed law, po, no, this is actually already inculcated in the health promotion framework strategy of the Department of Health, wherein we put in social behavioral change, education, and lifestyle modification into this one. But there is no specialized or there is no institutionalized training yet for this particular primary caregivers. So I would like to also to second the proposal po, no, for the education for this particular primary care workers and extend it also to those the different cadres that we have now. For our different cadres right now, we can see that in our ground, yung pinakamadami po talaga ng mga healthcare workers natin would be barangay healthcare workers, midwives, and the such. And I would like to recommend that we extend also the different capacity building to this particular cadres because they're the first line implementers po of health. So thank you po, Mr. Chair.
Thank you. Any more members? Cruzado.
Mr. Chair, if there are no more questions, I move to approve House Bill 2943 subject to technical consultation with stakeholders.
Second, Mrs. Chair.
There's a duly seconded motion.
Yeah.
Paul Vergara, before you.
My dear colleague, um, so naka-PPP ho kayo with Rockefeller Foundation?
Person po answer the
Yes.
question.
The Rockefeller Foundation actually supports many different endeavors and programs in terms of health, particularly what do you call this, non-pharmacologic interventions. And Rockefeller Foundation is providing education, venues, and resources, you know, to fund these programs. And the partnership that we have with them is coursed through our international affiliations. The Philippine College of Lifestyle Medicine is affiliated with the Lifestyle Medicine Global Alliance and the World Lifestyle Medicine Organization. And we're fortunate because just recently we had the representation for the Asia Pacific, and it was Philippines that was selected to represent the preventive and lifestyle medicine movement within Asia, because currently within Asia, we are the only and we're the first to have a structured training program and integration of lifestyle medicine within our healthcare system. So that was currently conducted just this month, in Bellagio, Italy. So it's course through our international affiliates, and they choose Philippines, as one of the four movers in this implementation throughout Asia Pacific.
So, Dr. Palma, hindi ho kami walang yung budget talagang makukuha namin para sa buong Pilipinas from the foundation.
Okay, sir. I cannot really speak for that because, in fact, these are group of funders. I was also amazed when I was there because you're facing funders and you just have to propose your program. And then they like what we're doing in lifestyle medicine. We're talking about food as medicine. We're talking about pack labeling, climate change, how planetary health is actually supported through lifestyle interventions, through the dietary interventions we offer. They are actually the ones who offered to support us in this endeavor. We did not know them initially. So they chose us, to be part of this program. But for me to say that they will provide fund for the Philippines, I couldn't really speak for that. But for the program, yes. Yes, sir.
Yeah. Program based. So, meron po akong anak na doktor eh. So, kaya ako nagtatanong din at nagliliwanag.
Kong, excuse
Kaya
me.
ganon.
Kong.
I agree with
Yeah,
Dr.
yes.
Kasi 68% nga yung, kahit po sa lugar namin, around 68% yung may problema, ang cause of death ay ganun po kalaki. Ano ho? So, talagang malaking bagay para sa atin na i-adapt yung measure na rep.
Yes, Kong,
Sige.
if I may add po, Kong, of course, our concern is, of course, as usual, the budget. But with this bill naman po, I think hindi naman masyadong malaki yung budget. And if ever, we also have budget from DOH for the prevention of this NCDs. And I think with that budget, pwede natin i-work on or i-realign siguro into this if ever ma-institutionalize po. So I think hindi naman po masyadong malaking budget yung natin, gamitin. Thank you.
Maraming salamat po. Mag-aaral po kami sa inyo.
Thank
Mr.
you.
Chair, if I may add, for the information of those who just heard lifestyle medicine for the first time, uh, I would like to take this opportunity to educate you a bit. In lifestyle medicine, we don't only talk about preventing your chronic conditions. Once we catch it early, our goal is to reverse it or for your diabetes to achieve remission. Once we catch fatty liver disease, our goal is to reverse your fatty liver disease because we know this is a spectrum. Once you have gone through the cirrhosis level, that's not reversible anymore. If we give budget for dialysis centers, why can't we give budget for patients who are at stage 1 to 3, where we can arrest progression of chronic kidney disease? And we're talking about years of delaying dialysis. Why can't we provide programs for those who have just had bypass operation or stent insertion, and then just after 2 years or 3 years, they get bypass operation again? So this is where the lens and interventions of lifestyle medicine can come in, because our goal here is for patients to develop that identity of taking care of their health and not just being medicated.
Thank you, Dr. Palma.
Mr. Chair, excuse me, last one. So in
Okay.
short po, in summary, we spend too much for the treatment. In our country, we spend billions of pesos for the treatment. Why not spend a lesser budget for the prevention compared to the more budget for the treatment? That's all, sir. Mr. Chair. Thank you.
Thank you, Honorable Gorriceta. Thank you, Honorable Vergara. We now act on there was a previous
Mr. Chair.
motion.
I
Mr.
second.
Chair.
Honorable
Yes, if I
Bautista.
may, Mr. Chair, I just wanted to manifest my support po to the bill. And I think I just, in relation to being educated po about the lifestyle medicine and having gone through the proposed bill. Um, and na-mention din po how we are spending billions on treatment. Maybe we can, just as a form of suggestion, if we can have um, more aggressive programs for the preventive portion, ma'am. Because as I understand it po dito sa inyong lifestyle medicine, it seems that parang it points to uh, clinical care. Kumbaga parang it assumes na meron na pong mga pasyente. But if we are talking about preventive, we don't want it to be a patient in the first place. So if we are to adopt lifestyle medicine, as a form of preventive care, baka po merong program na mas magfo-focus po na hindi po maging pasyente ang ating mga tao in the first place. And I think this was also discussed by the DOH in their programs last year po during po the budget hearings, that they're also looking into having programs in terms of preventive care din po and down to our community. Baka po the lifestyle medicine we can use as a form of a program to, I don't know, strengthen whatever DOH programs they have right now down to the community. This one po na bago pa man din po sila magkaroon ng mga sakit po or maging borderline pa man din po. Kasi kapag ka po kasi, as I understand, may mga doktor din po kasi akong kinoconsult. May mga maintenance po tayo, hindi po ba? Kapag ka um, tinuturo naman din po nila yung kailangan na lifestyle change. In addition dun po sa mga medical interventions that we have to go through. But then, ako minsan po iniisip ko, sana po nalaman ko nung simula pa lang na ganito na, that we are able to manage these things before we even become have contract these kinds of diseases or tumataas yung ganito, ganyan. Dapat magbawas kayo sa ganito. But if sa simula pa lang po, we know the lifestyle that we need to adopt or to watch out for. Baka po mas hindi na po kailangan in the first place na mag-manage even ng mga stage 1 na mga sakit po. So I think yun lang po yung suggestion po namin dito po sa bill na ito. If we can have more programs to have a more preventive approach po. Yes, ma'am.
Yes,
Thank you po.
Mr. Chair. Kong, thank you so much for the support and thank you for the suggestion po. That is in fact my question during the budget hearing to DOH na yung prevention natin na budget, bakit yan lang? No, and sometimes it just stops sa promotion like the caravans, the advertisements, social media, but hindi siya nakakarating sa grounds. Like for example, we should be like screening the patients first and foremost kung may family history na ng diabetes. And this is what the bill actually wants to implement. Na down to the BHWs, down to the community health workers, malalaman na kahit wala pang diabetes, wala pang hypertension, o ikaw high risk ka na kasi may family history, o ikaw obese ka na. So high risk ka na kasi nga overweight ka na. So yeah, that is exactly the bill. That is what exactly what I want to implement with this bill. Thank you.
Dr. Palma.
Um, Ma'am, thank you so much for the support to the bill. This is actually the very reason why we were calling for the integration and collaboration with the DepEd, with the TESDA, even with the agriculture sector. For the information of everyone, lifestyle medicine is not working within just the clinic. We have what we call the nutrition sensitive agriculture program that we work with the Department of Agriculture. So we utilize existing budgets that they have so that we can implement this in the community. We have proof of concepts and pilot programs that we have implemented even in the grade school area. For the information of DepEd, thank you so much for the support. We understand that it's already embedded in your subject, but this bill is actually calling for a structured intervention. And even with the DOH, the current existing lifestyle-related disease programs that we already have, it's already existing, but it's more educational rather than interventional. So we just have to reorient the system and we integrate education so that we have the lens and the competencies to provide these services.
Mr. Ch- Mr. Chair, I'd just like to manifest my support to the bill. And if it's okay with the author, we can be all members present can be co-authors. Thank you.
Of
Yes.
course. Oh, thank
Uh,
you.
let's approve first the bill, and then we can move that. Yes, Honorable Pancho.
Mr. Chair, before lifestyle medicine, existing na po sa atin yung mga nutritionist. 'Di ba? Parang ito yung work po nila eh. So ano difference po, ma'am?
Okay, let me answer the question, ma'am. The nutritionists and dietitians are actually dependent on the prescriptions also of the physicians. However, can you imagine if the lens of the physicians is not towards reversal of the disease and just maintaining the condition? So that will be implemented and given and prescribed to the patients as well. So let's say, for example, we all prescribe in our chart diabetes diet, but it doesn't mean that our goal is to reverse diabetes. So that's the difference. So in lifestyle intervention, this is where intensive nutrition prescriptions can come in. And there's more programs that would come in, not only just giving foods that are included in the food list. We are guideline based, and that's the gap. And whether we like it or not, the gap in implementing the clinical practice guideline recommendation towards clinical practice, we're talking about 5 to 10 years. Hindi siya nababasa ng mga doktor, paano nila i-order sa chart, paano i-implement ng nutritionist. Because doctors are so busy taking care of the acute conditions. So this specialty is actually focusing towards what we can do on the non-pharmacologic interventions.
Okay.
Excuse me.
Uh,
Just ano po,
okay.
addition. Kasi po, sometimes yung nutritionist po, they will just say, oh, mag-diet ka, mag-vegetables ka, mag-ganyan ka. But there's no monitoring po. Wala tayong output. So, in case na ma-institutionalize to yung bill, we will have monitoring. May mga BHWs na tayo na magte-train na to check na nagda-diet ba talaga? Yung food ba talaga healthy? So, I think that would be the difference ko. Thank you.
Honorable Roque.
Yes, Mr. Chair. Pasensya, papahabain ko na ng konti. Um, I'm actually also one of those na bago lang sa akin nga to. Pero all at the same time, I am only happy na the Department of Education is into this collaboration kasi I believe that we should start with the children. From the moment that we educate our children, that they should be having a better lifestyle, hindi yung junk food, hindi yung mga sodas na nakikita natin. Kasi I've seen schools here in Manila who has already implemented that. They actually educate the children and tell them this is not good for you because, not just because, kasi sabi ko, but because this will happen to you if you do this. But then again, I was hoping that we would be having a resource person from DTI, sana ba, or mga nagbebenta ng hindi naman talaga magandang mga pagkain. Lalo na yung mga energy drinks na sobrang ang effect. Kasi sa mga barangay, usually ang cause of death is andyan. So, yung ininom niya, ito lang yung parating kinakain niya. Tapos nakikita mo na nasa pagkain talaga nila, ang iniinom nila, ang dahilan bakit sila. So now that we are into this preventive lifestyle medicine, ang monitor. Pero maganda rin na ang dahan natin hindi accessible sa mga bata o sa mga matatanda o sino man nagtatrabaho na may mga pinagdadasal hindi maganda sa ating kalusugan. Kaya nga po, maganda po na mayroon nga tayong collaboration sa iba-ibang grupo. Pero all at the same time, sana nga magsimula tayo sa mga pag-educate ng mga tao. Lalo na rin po ang lifestyle din kasi nakikita na natin on social media. Nakikita na natin bakit di tayo kumain ganito? Dapat ganito na yung lifestyle natin. I've been changing my lifestyle na rin. I've been fasting. I've been doing everything that I see online. But the thing is, importante, bata pa lang ang mga tao from the schools, preschool, elementary, high school, college, everybody should be educated to prevent on becoming a patient. And then again, of course, very helpful talaga na may magmo-monitor sa kanila na nasa right direction din talaga. Yan lang po, Mr. Chair.
Thank you, Honorable Roque. Before I, yes, Honorable Acop.
First off, good morning, everyone. I'd like to express my support for the bill. Number two, I'd like to laud the efforts of the resource people. It does take a village to raise a child, but also the rest of the members of society. But lastly, I want to shed context to what we're trying to do. I was looking at the SDG, specifically SDG 3, to ensure healthy lives and promote well-being for all at all ages, and more specifically 3.4, which is to reduce by 2030 by one third the premature mortality from non-communicable diseases, cardiac diseases, cardiovascular diseases, pulmonary disease, and cancer. Uh, Based on the numbers po, from 2015 and to the most recent one, 2022, we have remained unmoved of our target. So numbers in 2015 reflect the same for 2022. So the thing is, I think we really need something like this to move the needle, or else we'll end up spending more money just to manage the problems arising from these diseases po. Thank you.
Before we proceed, we'd like to acknowledge the presence of a committee member, Honorable Iris Marie de Mesa Montes of Party List 4K, our Vice Chair, Honorable Walfredo Arman Dimagula Jr. of the Lone District of City of Binyan, and Honorable Keith Attorney Mike Tan of the 4th District of Quezon. Yes, Honorable Yatko.
Good morning. I'd like to manifest my support for the bill, but I'd like to also mention with DOH that we also have the first 1,000 days, diba? So that's the prevent. So bago pa mabuntis ang mga nanay, so kailangan na talagang napapaalagaan sila. And then we have this 1,000 days na yun yung connect sa prevention natin. So sana at least mapalakas ng DOH yung first 1,000 days natin. Mas lalong ma-promote. Thank you.
Thank you, Honorable Yatko. Any more? Yes, Honorable Pancho.
Ma'am, you mentioned a while ago that you will have the barangay health workers. Am I right, ma'am? Kailan mo mga volunteers lang sila eh. They lack training, ma'am.
And this is the reason why we really were calling for the collaboration with the TESDA, because they are the ones who can capacitate our barangay health workers through competency training po. They have competency trainings as discussed earlier from our representative from TESDA.
Alam ma'am, ang training nila usually 6 months lang. I think that's not enough. Kasi we're talking about life. Kaya nga, healthy lifestyle. The life of the people eh. So yung 6 months, I think that's not enough. Okay lang yun kung mga massage,
Yeah.
dressmaking, vulcanizing, welding, driving. Pero
So
when you talk
for
about health, the life of the people, I think 6 months is not enough. Chair.
if I may answer it, ma'am, by experience in terms of training programs, even health coaches, the training program for health coaches are also 6 months or even lesser. And since this is a behavioral change competency, you don't actually deal clinically. The clinical part would be the responsibility of the physicians and then the nutritionist. So the barangay health workers will be the ones who will be following up, and then monitoring. And so they should have the lens on what to monitor. And when we talk about behavioral change, it's changing the mindset of the people within the community. So definitely there should be a tailored fit competencies, at their level of education. Kasi po hindi lahat ng BHW po ay college graduate. Yes po. Kaya yung kanila po, if I may share, this program in nutrition sensitive agriculture is actually enhancing access to healthy foods. Kasi kahit mag-prescribe po kami ng healthy food, pagdating sa barangay, wala naman pong source. Sa 500 pesos nila, hindi aabot ang gulay doon at prutas. So there is a program, there's a lot of proof of concepts already that enhancing accessibility to resources. Like they already have barangays, they already have gulayan sa barangay, and what we're implementing are community teaching kitchen so that we teach mothers on how to prepare their foods. So yun po yung level ng barangay health workers.
In support to the program or the bill of our speaker. Yes, TESDA has our Barangay Health Services NC2, which this is actually a community focused 463-hour program teaching household health profiling, disease transmission containment, and healthcare reporting at the local sector level. So with regard to the data, I think on how many barangay health workers have been trained on this specific program. So maybe we can provide or we can submit our data on this. And also, just to inform everyone, we have our Test the Online program on this specific program, which is the Barangay Health Services NC2, which is this free for all to access in our Test the Online program.
Mr. Chair,
Yes, Honorable Pancho.
in favor of TESDA. Kaya lang, based on our experience, yung nga lang kit hindi nila bibigay on time eh. Inaabot ng 6 months to 1 year. So, observation, Mr. Chair.
Honorable Chair, sorry, I'll make this quick lang po. No? So, I agree po with our resource persons on different matters po, no? Especially when we talk about health education. Health promotion before was viewed as health education, but we're going farther from health education. We're actually looking for the social determinants of health. That is why the Health Promotion Bureau is having three major settings. Healthy learning institutions wherein DILG, TESDA, DepEd, and CHED is actually working with us. We have also our healthy communities wherein we're actively coordinating with the Department of Agriculture for the health sensitive and specific programs. And we also have the healthy workplace. So we support this one as we extend from health education to actually look into the social determinants of health. I would also like to second that this is not budget heavy. There are a lot of cost-effective analysis and a lot of cost-utility analysis that says that health interventions, if we're going to put it in preventive and promotive way, will actually give a lot of benefits for the government. That is why, Mr. Chair, I would like to reiterate that if we really push for this, is to have the Department of Health Promotions budget to be at 1% with universal health as mandated by the Universal Healthcare Act, which currently we did not reach the 1%. So this will actually also put into a lot of strain with our department, with our bureau when it comes to this particular implementation. And lastly, Sir Chair, about the training for our barangay health workers, we have different competency models and frameworks which are actually parallel with the practice and with the skill set of our different cadres. So we will be working hand in hand with the different stakeholders, with the lifestyle medicine specialists, so that we could have a more integrative and more nuanced curriculum for our barangay health workers. Thank you, Mr. Chair.
Thank you. There was an early motion by Honorable Cruzado, duly seconded, that we approve House Bill number 2943, subject to style and amendment. Do I hear any objection? Hearing none, House Bill number 2943 is now approved. Congratulations. Any motion to include those who are present as co-authors?
I move, I move that all members present be an author of this bill.
Second, Mr. Chair.
With the permission of the principal author, there's a motion by Honorable Sagarbaria that all those present here this morning be made co-authors of the said bill. Hearing no objection, the same is approved. Congratulations. Uh, Before we proceed to the last agenda, we'd like to thank our resource person on the preventive and lifestyle medicine. Thank you very much for your presence. You are now excused. We now proceed with the bills on e-health or electronic health. We now recognize um, the author of House Bill number 1387, an act establishing the electronic health or e-health system and services in support of universal health care using information and communications technology and operating funds, therefore, by Honorables Attorney Mike Tan and Honorable Iris Montes. Honorable Montes is now recognized.
Thank you, Mr. Chair. Congressman Attorney Mike Tan of the 4th District of Quezon, and I would like to thank the committee for the opportunity to sponsor this measure today. House Bill number 1387 seeks to institutionalize a system of providing wide access to quality health information and services using information and communication technology, referred to as the National E-Health System. This measure leverages ICT to provide universal access to quality health services, fulfilling a mandate recognized by the World Health Assembly as early as 2005. Building this digital infrastructure is a necessity for the success of the universal healthcare, ensuring that our poor, vulnerable, and those in geographically isolated and disadvantaged areas are not left behind. Once enacted, the NEHS will encompass all public and private providers, creating a unified ecosystem that complements existing healthcare standards through innovation. By institutionalizing this framework, we are not just adopting technology, we are reimagining a health system that increases accessibility while containing costs. This builds toward a more responsive and effective healthcare delivery for every Filipino. In view of justly ask the committee's favorable consideration of this measure. Thank you, Mr. Chair.
Thank you, Honorable Montes. Uh, Next is House Bill number 3115, an act establishing the Philippine Electronic Health or e-health system and services in support of universal health care and appropriating funds, therefore, by Honorable Ching Bernos. Honorable Bernos is now recognized.
Mr. Chair, I move that the explanatory note of the bill be adopted as the sponsorship speech. Thank you, Mr. Chair.
Thank you, Honorable Bernos. Next is House Bill number 7176, an act providing for national policy and regulatory framework for the Philippine telemedicine system, appropriating funds therefore, and for other purposes, authored by Honorable Salvador Prieto. Honorable Prieto is now recognized.
Thank you, Mr. Chair. Morning po, esteemed guests and our distinguished guests and colleagues. Allow me to sponsor my bill, House Bill 7176, entitled An Act Providing for National Policy and Regulatory Framework for the Philippine Telemedicine System. Mr. Chair, this measure is more than a technological upgrade. It is a lifeline for millions of Filipinos who continue to struggle with access to health care simply because of where they live. For decades, access to quality health care in our country has largely depended on geography. For many Filipinos living in remote provinces, island communities, and far-flung barangays, seeing a doctor often means enduring long travel hours, expensive transportation costs, and delayed medical attention. The COVID-19 pandemic changed that reality, and it accelerated the use of telemedicine across the country. Doctors began conducting consultations online, prescriptions were issued digitally, and healthcare services became more accessible even during lockdowns. But while telemedicine proved its value, It also exposed serious gaps in our system. Questions arose regarding professional liability, patient safety, data privacy, and the absence of clear national standards. House Bill 7176 institutionalizes telemedicine as an integral part of our healthcare delivery system. It establishes clear standards, safeguards patient rights, and ensures that virtual healthcare services remain accountable, ethical, secure, and at par with in-person medical care. More importantly, this measure strengthens the implementation of the Universal Healthcare Act by enabling the broader integration of telemedicine into our public health system, including health coverage for consultations. In doing so, we move closer toward healthcare that is truly affordable, accessible, and inclusive. Mr. Chair, telemedicine is not meant to replace the human touch in medicine. It is meant to extend its reach. Today, we stand at a crossroads. We can either allow technology to outpace our laws and leave our citizens vulnerable, or we can build a safe, responsible, and modern healthcare system that meets the realities of our time. In view of the foregoing, Mr. Chair and members, I respectfully seek the immediate passage of this measure. Thank you, Mr. Chair.
Thank you, Honorable Prieto. Next is House Bill number 9008, an act establishing a national electronic health record system to ensure continuity of care, improve medical efficiency, and promote universal health access for all Filipinos by Honorable Dr. Philip Conrad Acop. Honorable Acop is now recognized.
Thank you, Chairman Gato. Um, sa bawat konsulta sa clinic, sa bawat emergency room nating pinapasukan, sa bawat paglipat natin ng ospital, hindi lamang karamdaman ang ating dala, kundi kaba at pag-alinlangan. Kaba na baka sa gitna ng pagmamadali at pagkabahala, baka makaligtaan natin ang mga importanteng detalye ng ating medical history. Pag-alinlangan dahil madalas itong nangyayari sa kapwa nating mga pasan na may karamdaman. Isipin natin si Mang Cardo, 65 taong gulang, pamilyado, may high blood at diabetes. Mula sa kanyang liblib na barangay, kinailangan siyang itakbo sa mas malaking ospital sa lungsod. Ngunit sa gitna ng kirot na nararamdaman at kakapusan hindi lamang sa hininga, kundi pati sa bulsa, ang tanging bitbit niya ay isang lukot na reseta at malabong alaala. Sa emergency room, ang oras ay hindi lamang ginto. Ito po ay buhay. Ngunit imbis na agarang lunas ang sumalubong kay Mang Cardo at sa pamilya niya, ay ang paulit-ulit na mga tanong. Kailan po kayo huling nagpatingin sa doktor? May allergy po ba kayo? Ano po ba ang mga gamot na inyong iniinom? Nasaan po ang huling lab test results ninyo? Ang kwento ni Mang Cardo ay isang kwentong paulit-ulit na nagaganap sa mga klinika, sa mga emergency rooms, at kahit na sa mga kwarto ng mga ospital, oras-oras, araw-araw. Pero hindi dapat ganun. Mga kagalang-galang nakasama sa bulwagang ito, ang One Patient, One Health Record Act of 2026 ay hindi lamang isang technological progress para sa ating health sector. Mas importante, ito ay isang pagtugon sa kwento ni Mang Cardo at ng milyon-milyong Pilipino na hindi na dapat kailanganin pang magpaliwanag ng paulit-ulit habang namimilipit sa sakit. Sa ilalim ng panukalang ito, itinatatag natin ang National Electronic Health Record System. Tapos na ang panahon na ang isang pasyente ay biktima ng redundancy mula sa paulit-ulit na pangungulit ng mga mahalagang tanong hanggang sa mga laboratory test na kinakailangang ulitin dahil lamang nawala ang papel o hindi mabasa ang sulat kamay ng doktor. Kadalasan ang gastusing ito ay higit sa isang linggong sahod. Hindi dapat nasasayang ang perang pinaghirapan ng pamilyang Pilipino sa mga bagay na epekto lamang ng kakulangan ng ating sistemang pangkalusugan. Sa pamamagitan ng isang secure cloud system, binibigyan natin ang ating mga doktor ng isang komprehensibong clinical record na nagsusulong ng continuity of care para mas mapagtibay ang kanilang kakayahang mag-diagnose ng tama at magbigay lunas ito ng mas mabilis at ng mas maayos. inilalagay ng One Patient, One Health Record Act of 2026 ang Pilipinas sa mapa ng modern healthcare. Ito ay pagsunod sa ating Sustainable Development Goals, partikular po ang SDG 3, patungkol sa good health and well-being, at SDG 9, na patungkol naman po sa industry, innovation at infrastructure. Higit sa lahat, ito ay investment upang wakasan ang nasasayang na pondo, hindi lamang sa posibleng fraud or manual record inefficiencies, kundi dahil na rin sa system inefficiencies. The One Patient, One Health Record Act is foundational to any healthcare system. It is a significant step towards ensuring its cost efficiency by optimizing its impact on every Filipino like Mang Cardo. Ang panukalang ito ay ang ating panata, isang Pilipino, isang health record, isang mas makataong healthcare system. Maraming salamat po.
Thank you, Honorable Acop. Next is House Bills. Number 43 by Honorable Representative Ernesto Dionisio Jr. House Bill number 162 by Honorable Vincenzo Renato Luigi Villafuerte. House Bill number 1440 by Honorable Aniela Bianca Tolentino. House Bill number 1701 by Honorable Miguel Luis Villafuerte. House Bill number 2463 by Honorable Girly Veloso. House Bill number 2881 by Honorable Patrick Michael Vargas. House Bill number 4199 by Honorable Brother Eddie Villanueva. House Bill number 5601 by Honorable Howard Guintu. House Bill number 6705 by Honorable Christopherson Yap. House Bill number 6744 by Honorables Ferdinand Martin Romualdez, Yede Marie Romualdez, and Andrew Julian Romualdez and Honorable Jude Asidre. House Bill number 6759 by Honorables Ferdinand Martin Romualdez, Yeda Marie Romualdez, Andrew Julian Romualdez, and Jude Asidre. House Bill number 6915 by Honorable Christopher Sonyap. Honorable House Bill number 7851 by Honorable Alfred de los Santos. House Bill number 7866 by Honorable Brian Raymond Yamsuan. House Bill number 8437 by Honorable Representative Nelson Ligacion. House Bill number 8972 by Honorable Eric Goyap. And House Bill number 8975 by Honorable Eric Goyap. In behalf of the authors,
Mr. Chair.
there's also House Bill number 9008 by
Mr. Chair.
in behalf of the authors of the said bills, we now recognize Honorable Cruzado to sponsor in their behalf.
Mr. Chair, in behalf of the authors of House enumerated House bills, I would like to sponsor the measures and move to adopt their explanatory notes as the respective sponsorship speeches.
Thank you, Honorable Cruzado. For our resource persons, we now recognize from the Department of Health, Dr. Rainier Estrella.
Hello. Correction po, di po ako doctor. um, Good morning, Mr. Chairperson and honorable members of the committee. The Department of Health recognizes that an effective health system is instrumental in attaining universal health care for all Filipinos as it is not only enables easier access to health services, but also addresses disparities in service delivery and improves the flow of health information towards the achievement of better and equitable health outcomes. The institutionalization of critical health components on standards and interoperability, ICT infrastructure, health human resources, and capacity development, strategy and investments, and health services and applications will pave the way for foundational reforms by way of information and communication technologies or ICT that will be used to improve the delivery of health systems or health services rather. The DOH will submit its detailed comments and recommendations through a position paper upon approval by our Secretary of Health for the committee's consideration. Thank you, Mr. Chair.
Thank you, Mr. Estrella. From the Department of Information and Communications Technology, Mr. McNeil Adan.
Mr. Chair, distinguished members of the committee, and our colleagues in public service, good morning. The DICT would like to express its support for the proposed electronic health bills, recognizing their potential to advance a more accessible, interoperable, secure, and technology-driven healthcare system for all Filipinos, particularly those in GIDAS. The DICT remains committed to support initiatives that will enable seamless and secure health information exchange across both public and private institutions. We likewise stand ready to assist in strengthening the necessary digital infrastructure and systems that will promote interoperability, portability of patient records, and efficient delivery of healthcare services. In addition, DICT remains prepared to provide technical assistance and capacity building initiatives. Thank you, Mr. Chair.
Thank you. From the Philippine Statistics Authority, Mr. Oliver Changcoco.
Thank you, sir. Oh, okay. Yeah. Thank you very much, Mr. Chair and the honorable members of this committee. The Philippine Statistics Authority strongly supports the passage of the Consolidated eHealth Act, which seeks to establish the national eHealth system as an integrated, interoperable, secure, and sustainable platform for healthcare delivery across all levels of governance in the public and private sector. This legislative measure, which aligns with the campaign of the Philippine Statistics Authority for digitalization, collectively seeks to modernize, digitize, and digitalize and strengthen the Philippine healthcare system through telemedicine, interoperability, electronic health records, and e-health system. As the implementing agency of official statistics, the community-based monitoring system, the civil registration system, and the national ID, we commit to deliver relevant, timely, and accurate official statistics, inclusive civil registration services, and the implementation of the national ID as support to the authentication of our clients for this measure, Your Honor. And the official document for this or stand of the Philippine Statistics Authority will be submitted to the honorable committee once signed by the head of our agency.
Thank you. From the Department of Science and Technology, Mr. Paul John Serrano.
Good morning, Mr. Chair. For the Department of Science and Technology, we fully support the legislations on e-health. Particularly, we want this to be considered like investment in R&D that will foster emerging technologies such as use of AI or artificial intelligence for diagnostics, enhancing telemedicine platforms for remote communities, and accessible health data analytics for disease surveillance. Also, we want the bill to enhance sustainable and cost-efficient systems by prioritizing and support locally developed technologies that will potentially reduce the reliance on expensive foreign systems and enable long-term scalability. At the same time, we want the bill or the acts or the laws to provide evidence-based and context-specific solutions by supporting local research initiatives which enable solutions tailored to Philippine reality, such as geographic fragmentation, disaster vulnerability, and resource constraint.
Thank you, Mr. Serrano. From PhilHealth, Dr. Adeline Messina.
Good morning, Mr. Chair and
Mr.
honorable
J. Bernardo.
members of Committee on Health.
PhilHealth acknowledges and supports the intent of the proposed bills to institutionalize national telemedicine, electronic medical record, and e-health or digital health system that may improve continuity and coordination of care as envisioned in the UHC Act, enhance interoperability and health information exchange, support evidence-based policy development, to improve claims processing and fraud detection, as well as to strengthen healthcare access, especially in the GDAS. Likewise, PhilHealth supports the creation and composition of an interagency e-health or digital health governance mechanism. Lastly, to enhance operational efficiency, PhilHealth recommends the following five measures. One, to harmonization and consolidation of the proposed measures into a unified and comprehensive digital health framework anchored on interoperability, data governance, patient protection, and sustainability. Number two, the alignment with the UHC Act, particularly on Section 31st, which is supporting the National Health Data Repository, interoperability, and health information exchange covered by Section 36 of the UHC Act. Third is the inclusion and recognition of National Health Data Repository as the core component of the National Digital Health Architecture. Four, require all healthcare providers to maintain interoperable health information systems consistent with DOH standards and existing laws. And lastly, the pace and sustainable implementation approach supported by adequate investment in ICT infrastructure, human resource development, cybersecurity, and digital health capacity building. That's all, Mr. Chair. Thank you.
Thank you. From the Professionals Regulations Commission, Mr. Oves.
Good morning, Mr. Chair. The Professional Regulation Commission uh, supports the bills on interoperable electronic health system. We just have some recommendations. No, one, we would like to recommend that instead of individual-based record, we are proposing to have a family-based medical record. Uh, After all, some diseases are actually heredofamilial in nature. Second, we have to understand the existing family resources and the family psychodynamics. Uh, we have to identify who is going to be the suitable family caregiver. We also have to identify the financial support for the patient. We also have to know about the home environment as well as the cultural beliefs of the family. All of these factors will be affecting patients' health outcomes. It has been noted from researchers that family focused care will bring about better health outcomes compared to just individual based care. So that's the proposal. The other thing is this is a question because the primary care providers now will be caring for Filipino families and we need subscription to the electronic health record in order for us to be accredited or licensed by the Department of Health. So the cost of the electronic medical record is actually quite prohibitive for some of the primary care providers. So this is something that we want to be looked into as well. Thank you.
Thank you, Mr. Hoves. From TESDA, Mr. Aliado.
So, Mr. Chair, TESDA supports the establishment of a stronger and more integrated e-health system in the country. So TESDA also recognizes the importance of digital health systems in improving health service delivery, strengthening health information management, and expanding access to healthcare, particularly in geographically isolated and disadvantaged areas, or we call it GIDAS. So TESDA, however, respectfully emphasizes that the human resource development provisions of the bills should explicitly recognize TESDA's mandate over the technical, vocational, e-health workforce, while the bills refer to health or health-related and digital health professionals. Such terminology may unintentionally exclude technical and vocational workers who are essential to the implementation and operation of e-health systems. So this include health information technicians, medical records personnel, telehealth support staff, community digital health facilitators, and other workers who may not be licensed professionals under the PRC framework, but who remain indispensable to the effective rollout of digital health services, particularly in rural health units, barangay health centers, and government hospitals. TESDA respectfully submits that the development of the country's e-health workforce should not adopt an inclusive approach that recognizes both degree-level professionals and TVET-trained technical personnel. So TESDA's role in this area should therefore be expressly acknowledged as co-equal within the sphere of technical education and skills development. TESDA also welcomes the bill's recognition of non-formal and community-based training programs. TESDA's nationwide network of TESDA technology institutions, community-based training programs, mobile training initiatives, and community training and employment coordinators, or CTECs, may serve as effective platforms for delivering accessible e-health training, especially in underserved communities in um, GIDAs, or in geographically isolated and disadvantaged areas. In this regard, TESDA respectfully recommends that the Department of Health and the Department of Information and Communications Technology, or the ICT, in coordination with TESDA, be mandated to jointly develop and implement community-based e-health skills training programs supported by appropriate funding and budgetary allocations. That would be all, Mr. Chair. Thank you.
Thank you, Mr. Paliado. From the DILG, Attorney Noel Sala.
Morning po again, Mr. Chair. The department is yet to submit its official position paper on House bills on the subject House bills. However, we would like to convey our support on the proposed support. However, the department conveys its support on various House bills establishing electronic health e-health services systems act. The legislative measures seek to realize health information exchange to measure and monitor health system performance and responsiveness. Section 6 of House Bills number 2463 and 7866 require health facilities under local government units to fully integrate into the Unified Health Record System, or the UHRS, within 3 years from the effectivity of this act. The department acknowledges the government's policy on digitalization. However, there exist challenges in ICT services and local government units. Some LGUs lack IT personnel. Challenges is foreseen Challenges are foreseen in implementing this provision if no technical assistance will be given to LGUs by the appropriate government agency or agencies on this matter. Section 25 of House Bill numbers 1387 and 7851 require DILG to allocate at least 1% of its annual budget to e-health research and development. On this regard, our official position on this matter will be included in our position paper to be submitted to the committee. Thank you po, Mr. Chair.
Thank you, Attorney Sala. Next is from the National Privacy Commission, Attorney Arthur Benedict King.
Honorable Chairperson, distinguished members of the committee, other resource persons, magandang umaga po. On behalf of the National Privacy Commission, we thank the committee as well as the authors and sponsors of these bills for the opportunity to comment on this important and very relevant measure. The NPC fully supports the intent of these proposed bills. We emphasize at the outset that effective digital health implementation is complementary to data privacy protection. Patients are more likely to trust and use telemedicine, electronic health records, and national health system when they know their personal and medical information is protected. For the NPC, the central privacy issue is not whether health data may be used, it can and must be used to treat patients, save lives, and prevent the spread of disease. The real question is whether the law clearly defines who may access what data, for what purpose, under what authority, and with what safeguards. So in this regard, we respectfully highlight 3 points among many. We will send our position paper for the rest. But first, we raise the point of accountability. It should be clear. Where several actors are involved, such as the DOH, the PhilHealth, LGUs, hospital laboratories, and even private technology provider, the law should make clear who is responsible for the data, for the proper handling of the personal data. And second, consent should be properly situated within the broader lawful basis under the Data Privacy Act. In healthcare, data may also need to be processed for emergency treatment, public health, legal reporting, and other lawful purposes. So therefore, we should not overly focus on consent as the basis for lawful processing. And third, national system requires concrete safeguards. For proposals involving electronic health records, digital health IDs, national databases, or even field sys linkages, safeguards such as purpose limitation, data minimization, role-based access, audit logs, encryption, clear emergency access rules should be built into the law. We are very much encouraged that several bills already recognize privacy, cybersecurity, access controls, and patient rights. Our hope is that these safeguards will be strengthened as the committee works towards a consolidated measure. Uh, the NPC stands ready to assist this committee in the in technical aspect, the technology, even the drafting of the IRR, if you call on us to assist. We also request the kind indulgence of this committee to allow us to submit our written comments uh, later on. Thank you so much for this opportunity.
Thank you, Attorney King. And last is Department of Budget and Management, Mr. Rinaldo Moreno.
Muli po, magandang umaga, Mr. Chair. The DBM po recognizes the intent of the various bills on the e-health. We'd like to manifest our initial observation and comments. Una po sa lahat, doon po sa provision under HB 8437, HB 1387, and HB 7851 tungkol po sa earmarking. Doon sa 8437, meron pong earmarking ng 100 million. Doon sa dalawang bill po ay meron pong percentage earmark. So we would like to reiterate the policy stance of the econ managers on this, that we discourage earmarking of funds. Instead, we suggest for the usual upper language. Also, we would like to agree to the DALG as to the concern of the LGU. May mga provision po kasi na mayroong role yung LGU o minamandate yung LGU. So, kailangan po natin tignan yung capacity ng LGU on this. On the establishment po of the systems and data, our suggestion is to ensure na i-harmonize po ito sa existing to avoid duplication po. So we defer po sa DICT on this po. That's all, Mr. Chair. Thank you.
Thank you, Mr. Moreno. May I reiterate for our esteemed resource speakers to please submit your official position paper to this committee, hopefully by next week. The any interpolation from the members? Yes, Honorable Montes.
Yes, Mr. Chair, I would just like to comment dun po sa suggestion ng PRC. The PRC is recommending that we do a family based
family or the individual. So baka may mga, we will have to face some legal issues on that. Perhaps we can do a hybrid model on that. We use individual-based recording, but we can link the family members to the household. In that case, pwede pa rin po natin, we can still use the household for targeting naman po ito for mga social amelioration programs of the government. So napoprotektahan po natin yung individuals for easier care, and at the same time nagagamit natin yung records for the household naman for social protection. Baka po pong pwedeng ganon as Mr. Chair. Thank you.
In addition to what Honorable Montes mentioned, I think baka pwedeng pagka ang patient is minor, below 18, pwedeng isiguro as a family. Pero pagka above 18, baka we might be treading on the confidentiality issues. Siyempre, hindi naman lahat ng sakit mo kailangan alam ng mga kapatid mo o or in-laws mo. Baka kasama sa pamilya mo yun eh. So, yes.
Yeah, I brought that up because there are 6,000 family medicine practitioners in the Philippines, and their focus of care is actually the unit of care is the family. That's the issue.
Thank you.
And Mr. Chair, that will also make it easier for the interprofessional collaboration uh, as for the particular family for family members.
Thank you, Mr. Hoves. Any other questions, comments? Just one question. Is there such thing as 100% cyber secure? See, that's my concern for any online or electronic. Kasi confidentiality is a very important aspect of medical care and medical record system. So ang concern ko, and I think everybody's concerned, paano kung ma-hack yung records, medical records mo? Any comment from the ICT?
I'm not from Cybersecurity Bureau, but as ano po na as ano po na ang sa ICT, ang alam ko wala po talagang 100%. Kaya po we have to strengthen our policies, our infrastructure, the human resources. We have to train them. Yun po. Yun po yung controlled natin actually. Yun yung pinapalakas po natin. That's all po.
In the recent history ba, meron na bang na-crash or na-hack sa data, electronic data, like say PhilHealth or DOH? He wants to announce to the world that maybe Mr. So-and-so underwent vasectomy or, di ba?
Mr. Chair from PhilHealth. Though it's something critical that we need to discuss this matter because the intention of the law is that is the accountability of the processor is not limited only on whether it was intentional or accidentally exposed. So this is similar to what happened with PhilHealth. We've been at the limelight because of the Medusa at kami po ay nagdusa dahil doon. Though the data that was accessed or exposed was only for the PII, but not on the sensitive health data. So that's it, Mr. Chair.
The experience of other countries or more advanced countries, ano ba ang experience nila? Say US or Estonia, di ba? Estonia is noted for cybersecurity, etc. Nahahack din ba? Nagka-crash din ba? National privacy?
Good morning po. Wala akong specific information for Estonia. But of course, wala pong 100% na secure na uh, lalo na dahil pag mas maraming involved, mas mataas talaga yung risk kasi maraming access points. So ang pinaka-importante po is i-ensure natin na yung ating security measures are all in place and na regularly na-review natin. Uh, Kasi usually doon po tayo nagkakaroon ng problem eh. Uh, Baka okay siya nung start, pero baka hindi na-update and therefore later on nagbago na yung standard pero parehas pa rin yung system natin. So tumataas yung chance ng leak. And then of course, yung mga taong involved din. No? So kaya sinasabi namin lagi na purpose limitation, no? Sino lang ba talaga dapat ang maka-access? Kasi pag mas maraming may access, mas maraming uh, areas kung saan pwede magkaroon ng failure. Yun lang po, Mr. Chair.
If and when these bills be enacted into law, siyempre, una, dapat nationwide. And then interoperability, di ba, with other agencies. Do we have a ballpark figure on how much will this cost? A component? Or DBM?
Good morning po, Mr. Chair. As for the ballpark, will all at once or will do it in such a way that will build on local facilities first or on provincial level or city or municipality level, and then we'll build on those structures and then connect them together. So as of now we still don't have the exact figures, but we can I think we can work with our digital health steering committee, which is a multi-sector um, governance committee, on how or what we need to consider to build on these foundations. Thank you, Mr. Chair.
So maybe I request DOH and maybe DBM to please include that in your position paper, so that we will have an idea. Because definitely this bill will be referred to the Committee on Appropriations, and I'm sure that the Committee on Appropriation would like to know how much will this cost to our, I mean, from our national treasury.
Chair,
Yes, Honorable Cruzado.
Like to ask a question sa DOH or PhilHealth. We have already YAKA program and uh, profiling of patients, family, individuals done by hospitals and RHU. Is this already an initial uh, move for the digitalization of our health system?
Yes po, sir. The profiling po is part of the digitalization process. We need to first build up the registries, and part of the one of the registries is the patient registry. So we're currently building on those registries. Currently, we already have built up the National Health Facility Registry, the the for the insurance, and I think for other registries are already built up, and we need to update them uh, consistently. And also, we need to add other registries so that we can build the standards for the Philippines.
Thank you.
On the side of PLLTSPO, we recognize that IACAPS is the initial or the start of the build-up of the National Health Data Repository, but this is only part of the requirement under Section 31st, which clearly stated that all health and health-related data coming from health and health-related entities shall be submitted to the National Health Repository. So we agree po that this should be included as part of this e-health ecosystem. Thank you, sir.
Thank you.
Mr. Chair,
It's Honorable Cruzado.
if there is no more question from the group, I move that we approve House Bills number 43, 162, House Bill 1387, 1440, 1701, 2463, 2881, 3115, 4199, 5601, 6705, 6744, 6759, 6915, 7176, 7851, 7866, 8437, 8972, 8975, 9008, subject to style and amendments and comments of the Committee on Appropriation and for Committee Secretariat to prepare and file its corresponding committee report and approve the same.
Second, Mr. Chair.
There's a motion by Honorable Cruzada and duly seconded that the bills mentioned by Honorable Cruzada be approved, be consolidated, subject to style amendment, and for the committee secretariat to prepare the corresponding committee report and approve the same. Um, do I hear any objection? Hearing none, the same is approved.
Second, Mr. Chair.
It's a motion by Honorable Dimagila, duly seconded, that all those present in this meeting today be made co-authors of the consolidated and the substitute bill. Hearing no objection, the same is approved. There's a motion. There's a motion to
Second, Mr.
adjourn,
Chair.
duly seconded. Hearing no objection, the meeting this morning is now adjourned. Maraming salamat, dear colleagues, and of course our esteemed resource persons. Thank you very much for your time.